Hello, my name is Anna Maria Giraldi, and good morning, good afternoon, good day, good evening, wherever you are in the world. I'm so happy to welcome you to this symposium sponsored by Viatris, Broadening Our Understanding for Timely Diagnosis and Optimal Treatment of Erectile Dysfunction in the COVID Era. It's also called Love Life Again, and it's focusing on how the impact of the COVID pandemic has been on the love life of people all around the world. So thank you so much to the organizers for preparing this very interesting symposium in this very specific time of our life. And I also would like to thank my co-speakers. It's an honor and pleasure to be here with very esteemed co-speakers, Professor Giannini and Professor Mulhall. As I said, my name is Anna Maria Giraldi. I'm a professor in clinical sexology at the University of Copenhagen and also employed at the Mental Health Center in Copenhagen as I trained as a psychiatrist. And I'm also so happy that I'm here to introduce the symposium also as the president of the International Society for Sexual Medicine. And therefore, it's also a pleasure. And I thank you, Viatris, for planning this symposium. This is just to disclaim that the content that is presented represents the opinion and experiences of the different representatives that you will hear at the meeting. So this is our program. After my introduction, I will give a talk of the impact of COVID-19 of couple sex life. Then Professor Emanuele Giannini from Italy will talk about understanding the association between erectile dysfunction and COVID-19. And after him, Professor Mulhall from the US will talk about management of erectile dysfunction in the context of COVID-19. And then we have some time for questions and answers. So when we look at the impact of COVID-19 of couple sex life, so I will continue with my talk about the impact of COVID-19 on couple sex life. And those are my disclosures. So when we think about the human being, I think there are two things at least that can characterize us as human beings. One is that for most people, a sex life is an important thing. And I just want to share with you some data from a very large epidemiological study that was done in Denmark 2 years ago, where they had questions for almost 60,000 people that responded to the question, how important is it for you to have a good sex life? And as you can see, if you look at the purple bars, overall, a majority of people said that it was extremely important, very important, or important to have a good sex life. You can also see that a little bit more men than women say that it's important for them to have a good sex life. But I think we can conclude that for most people, it is important to have a good sex life. The other thing we can say about people is that people need each other. As a human being, I think just being a human, we need other people. We are social species. We like to be with other people. And social relatedness could be described among the basic needs for survival for the human being. So I think we can agree that COVID-19 has had an impact on the life of people all around the world during the past 2 years. And that has put a pressure on the mental health, a pressure on the social life, and a pressure on the sexual health. And that's what we are dealing with in this symposium. If we look a little bit on the mental health, these are some data from a review that looked at the impact of the COVID-19 on mental health disorders. And what they found was that what really stresses people or has an impact on mental health can be many factors. It can be the isolation. As I said, we are social human beings, so just being alone most of the time, which has happened for some people, can have an impact negatively on the mental health. The dependence of technology might create differences between people who have access to technology to people who do not have access to technology. Also, the overload of information about the pandemic can have a negative impact on people's mental health because you are like having so much information all the time about the COVID. You might increase anxiety, it might increase depression. Also, the courtesy protocol like face mask or not having face mask might have an impact on mental health. Face masks create emotional distance, and people who do not wear face masks for some reasons might experience that other people are not very friendly to them. Again, also a lot of people have had lack of employment or fear of losing their job. And also the COVID-19 has created or shown that we have socioeconomic disparities, that some people are more vulnerable in an economical way than other people are. So all these factors might increase the level of anxiety, sleep disturbances, and depression. There's also been reports of increased violence against women and children. And also, if we look at healthcare professionals, a lot of healthcare professionals have experienced burnout amongst themselves because there has been an extra pressure during the pandemic. This is a study where they looked at the perceived social support in the social distancing area. They looked at the association between circles of potential support and COVID-19 reactive psychopathology. What does that mean? They included a little bit around 800 people, and they looked at how the pandemic psychopathology was related to perceived support from one's close relationship, meaning the small circle in your life. Then they looked at the same in a larger circle, the perceived support from your community. And finally, they looked at how is the impact of the trust you have to guidance provided by the government on your psychopathological health. And as you can see, it's a quite large group in the age span. It's from 18 to 65 years, almost the same numbers in each age groups. So what they found was lower level of depression, anxiety, obsessive compulsive disorders, and PTSD was associated with higher perceived support in both the close relationship, in the higher sense of belonging to a community, and the more you trusted your government. And they also found that higher perceived self-efficacy in coping with the COVID-19 pandemic was associated with less depression. So this study shows that if you are feeling more secure in your small environment, in your middle environment, and in the larger environment, you also have a lower level of depression, anxiety, and other mental health problems. And also that if you feel that you can cope with the COVID-19 better, it will also decrease your level of depression. So if we look at sexual health, when we had the pandemic starting, there was a lot of speculations about what can the impact of COVID-19 be on sexual health. And this is what I'm going to present to you for the rest of the talk. Actually, there's been a huge amount of papers on sexual health and COVID-19. So I'm only going to present a few of them because we identified more than 150 papers on COVID-19 and sexual health. But there might be two different aspects of it. One could be that actually there would be an increased sexual health during the pandemic. And that could be because you have more time together with your partner, you're less distracted from work, maybe less stress from work, and also you can use it as a coping strategy to go through the pandemic. Much more focus has been on the possible decreased sexual health during the pandemic. And that could be due to the isolation. You have less family support. You have fewer coping opportunities in your life if something is wrong. You have less private time. And you have mental stress, as I just described, with depression, anxiety, anger, boredom, frustration, some of them. Also, people might have more economical concerns. There are less leisure resources. You might have to stay in your house, or we had to. Also, people would be afraid of contracting the virus. And also, there might be an increased partner violence. And finally, if we look a little bit to the overall healthcare, there might be less access to contraception and healthcare. And as I mentioned before, maybe women were a special risk for partner violence. So all these factors have been in play for what could happen during the COVID pandemic with sexual health. So what do we know from the literature? We know that if we see at the immediate effects, the first thing that was observed was that the day most of the world closed down on March the 17th, 2020, there was an increase on more than 10% in the pornography use. And I think that's quite interesting that the world closed down and more people watch pornography. And then the studies started to come about how is the pandemic impacting sexual life. And interestingly, the study was following the virus. So the first studies came from China, then we had studies from other parts of Asia, then we had a lot of studies from Italy, then we had studies from UK, and then we had studies from the US and other parts of the world. So in a way, the studies were following the virus. This is a study on a relatively young group of Chinese people. They were aged 15 to 45. It's about 270 men and 190 women, and the majority lived with their parents. And as we know, there were a lot of social restrictions during the pandemic. There was restrictions on social distancing, restricted travel and parties and outdoor activities. So what they found in this study was that when they asked people if there was a change in their sexual habits and desires, they found that a lot of these people, 50% of the males, 30% of the women, had a reduced number of sexual partners. They also found that for about 50% of the men and 70% of the women, sexual desire was unchanged, but there was a decrease in sexual desire in about 25% in both men and women. Also, they found that the sexual frequency was unchanged or reduced, and you can see that almost 40% had an unchanged sexual frequency and 40% had a reduced frequency. And then maybe it relates to the fact that it was a very young group. A lot of them lived at home with their partner, with their parents, so it was very difficult for them maybe to have sex and even find a partner. And when you looked at the sexual satisfaction, it's very interesting that overall 50% found that it was unchanged, and about 60% of the men said that it was unchanged, but 20% of the women actually said that sexual satisfaction increased. Then we have a study from Italy. This is also an internet study. It's a little bit older group. They're from 21 to 46 years. The majority, almost 100%, are in a stable relationship, and they have a high level of education, as 2/3 have a university level of education. And there's a majority of women in this study that included more than 1,500 people. And what they found was that with the pandemic, the frequency of intercourse per week went down. You can see to the left, you can see women, and to your right, you can see men. And you can see the purple bars are the frequency before the pandemic, and the blue bars are the frequency during the pandemic. And as you can see, there's a shift to the left, meaning that more people have no intercourse during the week, or maybe they move from having 2 to 4 to have 1 per week. And you can see, especially in men, there used to be 45% that had intercourse 2 to 4 times a week. And when the pandemic came, it was reduced to almost 25%. So there was a decrease in the frequency of sexual intercourses in couples during the pandemic in the beginning. They also asked them about other aspects of sexual life. And you can see if they looked at sexual desire, it's very interesting, because almost 70% of the women said that their sexual desire was unchanged or even higher, and only 1/3 said it was reduced. And it's quite the opposite in men, because 20% said it was unchanged or higher, and almost 80% said it was reduced. So there's a very large difference in the study between desire in men and women during the pandemic. Also, they ask about masturbation, and you can see in both groups, about 60% said it was unchanged or increased, and about 40% said it was reduced in both men and women. So the main reason they gave for decrease in masturbation was the lack of privacy and desire, because there was also the problem by all people being at home, so maybe you have less private life to actually be able to masturbate. So this is a small study from Egypt. We're moving to another part of the world. And the focus in this study was whether the impact of the pandemic was higher on women than on men. And we have the same picture in Egypt, where everything was locked down. There were restrictions on your social life, and they included almost 500 women and around 200 men. And you can see here again, it's a relatively young group. They're from 35 to 45 years. So when they looked at sexual satisfaction, they asked them whether it had changed compared to before the pandemic. And you can see that the men said had a higher level of sexual satisfaction before the pandemic than during the pandemic, and the same goes for women, but overall women had a lower level of sexual satisfaction. So they also looked at satisfied with sexual performance during the pandemic, and you can see that there's a difference between men and women. Men were more satisfied with their sexual performance than women were, and also women were in a very high risk of sexual dysfunction compared to men. The problem with the last one is that we don't have any data from before the pandemic, but you can see that women have a very high risk of sexual dysfunction, and that's why the focus is on whether women are hit harder by the pandemic in this study. Another small study here is a study that are including people from India, Nepal, and Bangladesh. It's a small study. They only have 120 respondents. Again, the mean age is around 35, and the majority, to 78%, are males in this study. What they found was that I think is very interesting is that when they looked at sexual intercourse, they found that 76% had intercourse 1 to 5 times per week, and it was almost the same during the lockdown. But what they also showed was that 50% said that the pandemic and the lockdown had affected the emotional bonding in a positive way. So here they actually find one of the positive things you might have discussed, whether there would be an impact on intimacy and emotional bonding in couples because they were more together during the pandemic. So these were some of the first immediate effects that were reported related to the pandemic and the impact of the love life of these couples. So what happened when we got a little bit further on in the pandemic? This is a study from the United States where they included more than 1,000 people, a little bit more men than women. The mean age was around 39 years old, so again, a relatively young group. And what they are looking at is how has the COVID-19 pandemic impacted the frequency of various partnered and solitary sexual behaviors, sexual function, satisfaction, relationship satisfaction, and intimate partner violence. I'm not going to report on the latest one. But they are asking people later on in the pandemic. So now people are used to the restrictions, and also some of the restrictions has eased again. So what they found was that a lot of the aspects really did not change a lot. You can see that sex with the current partner was unchanged for 50%, so was sexual desire. The masturbation was unchanged for 65%. The level of sexual satisfaction was unchanged for almost 70%. And the sexual enjoyment and pleasure was unchanged for almost 70% too, as well as pornography use. Where they really saw a change was that sex with a casual partner was reduced in 50%, and having an affair was either increased, unchanged, or reduced, as it was almost 1/3 that said yes to each of them. So this indicates that a little bit further on, when people got used to it, when people had not so many restrictions anymore, it has moved towards something that is where it was before. So to finalize, I think the take-home messages are that though I mentioned there is an increased number of studies, we still have a limited number of studies. A lot of them are small, and we don't have any long-term studies. We can see that COVID-19 has changed the frequency of sex in most studies I have presented. We can also see that it has changed sexual behavior to a variable extent, depending a little bit on who you are. And it might have positive and negative effects on sexual function, but most research has been focusing on the negative effects. So I would like to thank you, the organizers, again, and thank you for listening to my talk.
Thank you, Anna Maria. And I want to also to thanks very much both the International Society of Sexual Medicine and Pediatrics for organizing this very interesting symposium about the current pandemic. My name is Emanuele Iannini, and I am a full professor of endocrinology and sexual medicine in the University of Rome, Tor Vergata. My duty is to discuss with you how we can understand the association between ED, erectile dysfunction, and COVID-19. Those are my so-called disclosures and the agenda of this little talk. Basically, there are 3 points that we will discuss together. First, how erectile dysfunction is to be considered as a risk factor for the COVID-19 disease, for the COVID-19 pandemic, and so on. The second point will be the vice versa, how the COVID-19 is to be considered a risk factor for ED itself. And finally, the last point that I hope will be an interesting topic, an interesting novelty, is how we can consider erectile dysfunction as a biomarker for a new challenge we are facing right now, which is the long COVID syndrome. In other words, what happened to the people survived from the disease. First, erectile dysfunction as a risk factor for COVID-19. Basically, we performed, and we published at the beginning of the year in the Journal of Sexual Medicine, the largest study regarding the effect into the couple, into the individuals of the lockdown in Italy, because Italy was the first country or Western countries facing the pandemic, and the first country using the lockdown strategy into a severe manner. So we collected about 7,000 records from Italians using a well-validated set of psychometric tools in order to demonstrate the correlation between anxiety and depression and the lockdown itself and the sexual activity. Basically, we demonstrated in this survey that there is a lower prevalence and a lower severity of anxiety and depression in the subjects who performed well sexual activity during the lockdown, while on the contrary, the people who stopped the sexual activity during the lockdown were affected by more high level of both anxiety and depression. And the female sex was more prone for this psychopathological reaction with respect to the male one. So while we know very well that the male are more severely affected by the COVID, on the contrary, anxiety and depression were more present in women. From this huge data set, we went to understand if there is a correlation between the presence of the COVID as in this large population and the erectile dysfunction itself. And actually, we found a very strong odds ratio for having positivity for COVID-19 in patients affected by ED, by erectile dysfunction, and a finding which was not so clear-cut present in such a significant way in the female. So confirming that the female gender is less at risk of COVID. While in the male, yes, there is this clear correlation, this huge odds ratio of having COVID in the patients with a previous erectile dysfunction. The point is why there is such a correlation. We published in Andrology using this provocative title, Mask Up, to keep it up, in order also to motivate scientists, doctors, experts in sexual medicine, and patients for this purpose. This is the reason why there is such a correlation. Basically, this is the very bad tree of the non-communicable chronic diseases. That tree is growing into a bad grass, and the bad grass is based on the presence of lifestyle-dependent issues, which are also provoking erectile dysfunction, like cardiovascular diseases, like oncological diseases, endocrinological and metabolic diseases like diabetes, as well, of course, respiratory diseases. All these things are basically based on the lifestyle: unhealthy diet, excess of alcohol substances, physical inactivity, and tobacco use. And what is very interesting, and I did highlight this point in this review I published in Sexual Medicine Reviews a few years ago, about the fact that ED is the perfect biomarker of non-communicable chronic disease, sharing the same mechanism, the same pathophysiological mechanism, and having both non-communicable chronic disease and ED the same lifestyle role. Be careful, because indeed, having a non-communicable chronic disease, or a cluster, as frequently happens, of non-communicable disease, it is itself a reason for having COVID-19. So the cardiovascular, the metabolic, the oncological, and the respiratory are all producing increased risk of COVID-19, of the COVID-19 severe disease, and so on. So the non-communicable chronic disease and the virus are very much correlated. And in the same way, we can say that it's the same for erectile dysfunction, being the erectile dysfunction, as I said, a perfect biomarker of the non-communicable chronic disease. So in our era, in the COVID-19 era, we can go from the communicable, acute communicable disease, which is COVID-19, to the non-communicable chronic disease, which are the lifestyle connected disease, and vice versa. So this is putting sexual medicine, let's say, into the center of the story for this role for the prevention and therapy of erectile dysfunction that I said is a perfect biomarker for this. COVID-19 as a risk factor for EDs. Now we can go into the vice versa. Basically, in this review article, I was with my co-workers addressing the male sexual and reproductive health in the wake of the COVID-19 outbreak. The current evidences are suggesting that COVID-19 is indeed a potential risk factor for the sexual dysfunction, particularly male one, through multiple pathophysiological mechanisms, not completely, not fully identified, understood. But we know for sure that COVID-19 is producing endothelial dysfunction, which is a great reason, a terrible reason, but for ED, for erectile dysfunction, as well. COVID-19 is producing subclinical hypogonadism, low testosterone, and this is another reason for erectile dysfunction, is impairing the pulmonary hemodynamics, the pulmonary function, and this is reducing the oxygen tension to the penis and producing erectile dysfunction too, as well as I demonstrated before, the psychological distress. So all those things together with something else that I will show you later are producing the erectile dysfunction. So the connection is very strong, it's very clear. COVID-19 as a paradigm biomarker of sexual health and vice versa, because the endothelium is a target for SARS-CoV-2, for the virus. There is a clear target into the endothelial cell, which has been demonstrated many, many times. We know quite clearly which is the entry point into the endothelial cell of the virus, how it is producing a cascade of cytokines, of inflammatory molecules, producing thrombose and so on. This is the same which is affecting into the penis the erectile dysfunction, which has been in fact confirmed by the presence, by the localization in this American study of the virus within the endothelial cells. but also COVID-19 is affecting the cardiovascular function. There are many evidences showing that the appearance of the cardiovascular complication, both in short term and in long term, are producing the worsening of the vascular dynamics needed to maintain the erection, and the pulmonary fibrosis is further complicating the picture, as hypoxia is reducing the availability of oxygen for the synthesis of the starting of the erection, which is a nitric oxide into the corpora cavernosa. I stated that another weak point of the system is testosterone, the Leydig cell. It has been found that the presence of the entry point, the S2, into the Leydig cells could be considered the reason for a possible testicular damage produced by the COVID-19, producing this kind of subclinical hypogonadism. We have to demonstrate with the most strong evidences, but it seems that the research is going in this direction. Another point which is interesting in this is the fact that both anosmia and dysgeusia are present as a typical pathognomonic of COVID-19. And this is further correlating the story, because smell and sex have a huge connection. And even if right now, we do not have yet scientific evidences connecting directly the anosmia produced by COVID-19, very well described, and the worsening of sexual function. We may hypothesize it, because the correlation between the rhinoencephalus, between the smell and the sexual activity and desire and so on, is very well known. So we can predict a correlation also on this point. Regarding the correlation between COVID-19 and the psychosexological aspect, the psychopathological aspect is so clear. We demonstrated first, but many other articles demonstrate further that there are greater difficulties into the interpersonal relationship and producing anxiety as another mechanism reducing the level of the sexual health. Our results, my colleagues, have been very much found interesting into the media. And for both the article in the journals of endocrinological investigation and that one in andrology, both have been the record for both journals as mentions into the media as measured by the so-called attention score. So it seems that those findings have been considered very interesting. The last point is about considering erectile dysfunction as a biomarker for the so-called long COVID syndrome. The long COVID syndrome is a cluster of symptoms. It's a terrible problem that we are currently facing, where there is dyspnea, fatigue, anxiety, to be considered between the chief complaints of COVID long haulers. However, other residual effects of SARS-CoV-2 have been identified and more recently reported. This condition has been defined by the National Institute of Health and Care Excellence as the persistence of symptoms occurring during or after SARS-CoV-2 infection in the absence of other possible medical explanation. In this huge cohort of symptoms, strange enough, nobody was considering the sexual symptoms, which are indeed to be considered. This is very common for us as experts in sexual medicine to be considered the very last point of medicine, while we are the first. Because, as I said, the sexual COVID, the sexual symptoms are so perfect biomarker of non-communicable diseases symptoms, which are indeed closer to the long COVID syndrome, as I mentioned. And in fact, this cartoon I'm going to finish are is showing how the infection is producing the acute disease, as well the long-term complication known as long COVID syndrome, which is characterized by neuropsychiatric complication, by cardiovascular complication, by pulmonary and endocrine complications affecting many glands, many metabolic functions, and this is producing also the need for severe treatments, huge treatments, is producing the post-traumatic stress disorder, is producing a socioeconomical vulnerability, which is into a system sexology perspective. The system sexology is a new perspective of sexology, which is considering all those things together, producing multiple factors, leading to an increased risk of developing erectile dysfunction. And in this article, I submitted to the Sexual Medicine Review, highlighting this flow, showing the relationship between back to the initial point, to the lifestyle, back to the COVID and the long COVID syndrome and the sexual dysfunction as a non-communicable, as a communicable disease like COVID is exacerbating or being the main cause of the sexual dysfunction, also called the sexual long COVID. The sexual long COVID is indeed a new taxonomic entity, which is to be considered as a new biomarker in order to follow up the long COVID itself. So in other words, if you have a patient with a long COVID, just ask him how is going how is your sexual function? How is your erection? And how is you need to be treated for your erection? And you have a perfect biomarker of the long COVID itself. This is the idea that we are now exploring, having this new taxonomic entity, the sexual long COVID. So the conclusion, love life again, is that we have a lesson from the coronavirus. The lesson is we can learn much more. Unfortunately, we have to learn this lesson because the long COVID is really changing our generation, is really modifying also medicine. But in this dramatic situation, a role is raising, which is the role of the sexual physician, which is appearing as dramatically pivotal in facing pandemic, in facing this pandemic, and in facing the future pandemics that we have in front of us, as well the social and sexual consequences of the lockdowns, as well the disease themselves and the long-lasting consequences. So I wanted to conclude stressing once again that sexual medicine is not the last part of medicine, but it is the center, if not the beginning of the medicine itself. Thank you so much for your attention.
Hello, it's my pleasure to be here. I only wish that we could be together face to face. It's my great honor to present today alongside my two dear friends and colleagues, Emanuele Giannini and Anna Maria Giraldi. And today I'm going to talk about the challenges that have been presented to me as a sexual medicine physician working at one of the epicenters of COVID, New York City, in 2020 and the earliest part of 2021. I'm a urologist who is essentially a sexual medicine physician. I work at Memorial Sloan Kettering Cancer Center in New York City, and I'm the current editor-in-chief of the Journal of Sexual Medicine. You've seen this disclaimer already. These are my disclosures. Journal of Sexual Medicine, I'm on the board of directors. I'm a past president of the Sexual Medicine Society of North America, and I'm a consultant to Vault Health. So the challenges in the management of ED during the COVID-19 pandemic, this was an incredible challenge in New York City. My nurse practitioner, one of my nurse practitioners, was the second clinician at Memorial Sloan Kettering to get COVID-19. And that happened at the end of March. And immediately we closed down and went to completely virtual for 4 months, would you believe? So we were tremendously challenged with an incredibly busy practice, 4,600 patient visits a year, 4 nurse practitioners, 2 nurses, and it was a huge challenge for us, and we learned a lot of lessons over the course of that year. Dr. Giraldi and Giannini have done an excellent job at laying the background for my discussion, talking about the link between COVID and erectile problems. The pathogenesis of COVID-19 pandemic-related ED is absolutely fascinating to discuss, but has a less crucial impact on ED management. We should accept that in some patients with new onset ED, endothelial or hormonal alterations in this condition play some role. However, the clinical analyses that have been published and the database mining studies can never infer causation. I think you're very familiar with the structure of the penis, the sinusoidal structure, smooth muscle lined by endothelium. And in the flaccid state, the smooth muscle is under tonic adrenergic control. We're flaccid because the muscle is contracted and the lacunar spaces are tight and resist blood flowing into them. Under nitric oxide control, the muscle relaxes and then blood flows into the lacunar spaces, which are now wide, and it causes changes in endothelial function and maintenance of erection. So muscle tone in the penis is critically important. In states of high adrenaline, stress, frustration, anxiety, lack of confidence, this muscle is tonically contracted and resists relaxation during arousal. And this is why many men with high adrenaline have erection problems. The pathophysiology of organic ED really boils down to 3 things: endothelial damage, neural injury, and smooth muscle damage. Endothelium can be damaged by any vascular risk factor, hypertension, dyslipidemia, cigarette smoking, obstructive sleep apnea, coronary artery disease, etc. Neural injury in conditions such as diabetes and in patients who've had radical pelvic surgery or radiation therapy. But the final common pathway to permanent and severe ED is collagenization of smooth muscle. We must not ignore the role of the brain. The brain is the trigger for erectile function. Medial preoptic area, paraventricular nucleus, dopamine-directed triggering of erection. And when there are central issues, then there is a slowing in the process that leads to erection. And so part of the whole adrenaline-mediated erection problems, what historically has been called psychogenic ED, starts in the brain. I think you've seen this slide before. I just want you to concentrate on the middle box. So these are the effects of COVID: neuropsychiatric complications, cardiovascular complications, pulmonary complications, and endocrine complications. And all of them are known factors in the development of erectile dysfunction. We have seen some very interesting, very preliminary data, transmission electron microscopy, database study, that show a link between COVID-19 and ED. However, the final pathophysiology is unclear at this very preliminary juncture. On the right-hand side, you'll see side effects of treatments, post-traumatic stress disorder, and socioeconomic vulnerability. And all of these factors combined contribute to erectile dysfunction. I went to the internet the other day, I went to Google, and I plugged in a number of factors associated with ED, prostate cancer, and I came up with 75 million hits on Google when you combine erectile dysfunction and prostate cancer. And when I looked at diabetes, that was 436 million. And when you look at COVID-19, it was 2.9 billion. 2.9 billion hits for the link between COVID-19 and erectile dysfunction. Just incredible in the space of approximately 18 months. The effects of COVID-19 on sexual health, well, there are some factors that might improve sexual health. More time together at home in a harmonious relationship, less distraction from work, and coping strategies. However, on the other side, and probably more likely to have an impact on erectile function, are those factors that worsen sexual health. The social isolation, decreased private time, especially in New York City, people living in apartments with 2 young children, 4 people stuck in the same apartment for months at a time. Stress, depression, anxiety, anger, boredom, and frustration. Well documented that the COVID-19 has resulted in increase in sexual boredom. Economic concerns, less leisure time, fear of contracting the virus, a huge issue in my practice. Increased partner violence, again, well documented, published in the Journal of Sexual Medicine. and lack of access to healthcare. So there's been a tremendous opportunism associated with COVID-19 and research. And this is not just in sexual medicine, this is across the spectrum of healthcare. And we've had a plethora of submissions on COVID-19 over the course of the last 18 months, many of which are just not very well done, but these are the highlights. We have excellent publications in JSM looking at the link between COVID-19, the pandemic, and sexual problems in men, women, and couples. This comes from Bud Burnett and Dr. Tsay's excellent review article in Sexual Medicine Reviews on COVID-19 and ED, discussing the biological impact of COVID-19 on ED. We've already had that discussion this morning. Psychosocial impact of COVID-19 on ED, impact of COVID-19 on the management of ED, which is really what I will focus on, and the concept of health disparities and the impact of COVID-19 on ED. And I think we're all in agreement that health disparities exist in the management of ED and have been amplified by the pandemic. This is the famous process of care model, originally published in 1999 and now republished in 2018. We had a panel, including Dr. Giraldi and myself, which went over this. There has been nor has it been suggested there should be any change in the management algorithm for ED when associated with COVID-19. So we still manage people the same way. The American Urological Association guidelines on ED has downplayed the process of care model, which I don't agree with. And we still use the process of care model in my practice. So when you look at the efficacy of sildenafil citrate in the form of Viagra, and you're looking across various populations of men with ED, organic, mixed, and psychogenic, on the left-hand side, you will see the ability to achieve an erection. And on the right-hand side, the ability to maintain, both of which are critically important to erectile satisfaction. And the y-axis is the IIEF score, scored from 5, which is almost or always or almost always, and 1 is never or almost never. You can see a pretty dramatic increase in the scores across all etiologies. Now, I do want to say to you that when we're assessing the etiology without investigations, there is a certain inaccuracy in that. So when we diagnose somebody with psychogenic ED by just speaking to them, that is not always 100% correct. But irrespective of that, you can see that this is a highly effective agent, getting erections and keeping erections across a very wide variety of etiologies of ED. If you look at different medical conditions and the success rate with Viagra, you can see across diabetes, ischemic heart disease, peripheral vascular disease, radical prostatectomy, hypertension, depression, used antihypertensives and used antidepressants, you can see a very significant improvement in erectile function when using Viagra. Of note, if you look at radical prostatectomy, which is a large proportion of my patient population because I'm working at a cancer center, you'll see it has a very low or relatively low response rate. And the reason for that is very simple. They have a lower motor neuron lesion and their pelvic nerves are injured, and you need those nerves intact for PDE5 inhibitors to work. If you look at the EDIT, the Erectile Dysfunction Inventory of Treatment Satisfaction, generally speaking, a score above 50 implies satisfaction. On the left-hand side, this is the patient responses. On the right-hand side, this is the partner responses. You can see sildenafil versus placebo, significantly elevated scores in the EDITS questionnaire for both men and women, with actually impressively higher scores in the partners. And this is well documented in the literature. And then finally, when you look at adverse events, this is from Francois Giuliano's excellent review paper about a decade ago, and you can see the rate of adverse events decreases with increased use. This was seen very early on in clinical trials. Dr. Cully Carson published a famous paper many, many years ago looking at this, and Francois just updated the data that when men have side effects, headache, nasal congestion, facial flushing, blurred vision, etc., that when they continue to use the medication, the side effects go down with repeated usage, which is seen routinely in my clinical practice. So Viagra is an effective and a safe medication. So the challenges in ED care with COVID-19 are numerous, and a detailed discussion on all of them are beyond the confines of this discussion today. Decreased size of workforce due to relocation of resources. We have, as I said, 4 nurse practitioners, 2 nurses, and I had 2, 1 NP and 1 nurse taken away from me at Memorial Sloan Kettering because they were redirected to the ICU or the floors to manage COVID patients. So we had an instantaneous reduction in the workforce in my practice to take care of my patients. Necessary and laudable, but problem for the practice. Reduced patient volume. We had many patients who were refused to come into New York City, which, remember, back in May, June, July of 2020 was an epicenter for COVID-19. Compliance issues, psychological overlay. So it is clear to me that those patients who had baseline anxiety and baseline depression had both of those amplified dramatically during the pandemic. And so we had many patients who had been on long-term intracavernosal injection or long-term testosterone therapy who became non-compliant with therapy, changing their dose themselves because their injection therapy dose was not working due to excessive stress levels at home, not getting their blood work done when they're on testosterone therapy. We had numerous challenges with our patients. Mental health issues and laboratory assessment delays. So we had many patients in my practice who were on testosterone, who needed to go get their testosterone levels checked on the testosterone therapy, who got delayed because they were anxious and nervous and concerned about going to a laboratory to get blood testing done. And this represented a significant challenge in our very busy testosterone practice. Again, from Dr. Burnett's excellent overview, disruptions in medical care access and delivery seen during COVID-19. Well, we didn't have any clinical practice face-to-face for 4 months, and everything was virtual. But the volume of patients that we could see virtually versus in person was significantly lower. So we had patients who went months and months, who needed to be seen, who could not be seen. Now you might say to me, well, my patients don't have active cancer and we're not depriving them of cancer care. But when they were stuck at home with their partner day in, day out, and they wanted to have sex and they couldn't, it amplified the psychological reaction to the ED. There was tremendous and remains tremendous anxiety about visiting doctors' offices. We still have people in the New York area, outside of New York City, who refuse to come into the city to see me because of fears of catching COVID-19. There's been a dramatic increase in telemedicine utilization, a reduction in access to pharmacotherapy training. So for example, when we closed down for 4 months, no patient was able to undergo intracavernosal injection training. Now, this is a massive problem at a cancer center with a big penile rehabilitation program, where routinely 85% of my post-prostatectomy patients end up having to consider penile injections within the first 6 months after surgery. That was not available to my patients. And so this is a real problem in our rehabilitation program and caused tremendous stress for the team, but also for our patients. A reduced access to surgical care. We did not operate for 4 months. We had many patients who were scheduled to have penile implant surgery or penile curvature correction surgery who no longer could undergo those procedures. And so they had to be postponed, causing tremendous stress for many of those patients. And of course, these effects are routinely and were amplified in minority populations. It is estimated that 96% of Americans own a smartphone and more than half own a tablet. Already, nearly 2/3 of healthcare professionals expect that their commitment to telemedicine will increase significantly over the next 3 years, and I believe that will be the case. Of those providers who have not adopted telemedicine to date, nearly 85% expect to implement telemedicine in the not too distant future. And from 2014 to 2018, the adoption of virtual visits has increased in healthcare by 30%. And I expect that that figure has increased dramatically since the pandemic started. Sexual medicine is ripe for the use of telemedicine. There are many conditions, there are many things that we can talk about on a video visit. However, telemedicine is not an excellent strategy in many patients with sexual problems, at least for the initial visit. And that was our experience, that it was a substandard, subpar encounter when we couldn't see the patient face-to-face, when the patient's partner couldn't attend the video visit or could attend face-to-face, and especially when a physical examination was required. So the challenge is, of course, if you have a man who is seeing you for Peyronie's disease, for example, or for hypogonadism, the physical examination in both of those men is critically important. And of course, video visits do not allow us to do that. Patients in need of a procedure. I've already talked about those patients who needed intracavernosal injection training, patients who need a penile duplex Doppler ultrasound, or those patients who were using implantable testosterone, coming in with Testopel every 3 months. And then, of course, there were no visits face-to-face for 4 months in my practice, representing a huge challenge. And those patients have to move from implantable back to other therapies. But many of my patients on implantable testosterone were using implantable testosterone because the other strategies hadn't worked, or they just did not want to try the other strategies. The classic example will be the 35-year-old testis cancer patient who was 2 children at home, 3 years of age and 2 years of age. And we do not feel comfortable prescribing transdermal testosterone to those men because of the very high risk of transference. Interruption of training. There's not been a lot of discussion about this or literature published, but our trainees had less access to patient visits. And while we had encouraged them to attend our video visits, it's not the same as having a face-to-face encounter with the patient, with the trainee present. So I think we'll see over the next 2 years increasing attention to how the pandemic and how telemedicine impact upon trainee education. And of course, there are certain populations for whom telemedicine is very challenging. Language, those who don't speak English in the United States as a primary language, and those with cognitive impairment, often very challenging to conduct a video visit with those patients. There are also older patients in my practice who are technology challenged. They don't have a smartphone, they don't have a tablet, they don't know how to access the internet. We have a portal system at Memorial Sloan Kettering for texting our clinicians, and we have many patients who are just uncomfortable using the portal system. So telemedicine for those patients was a huge challenge. There are reimbursement concerns. I will say that most states and the federal government very rapidly, when the pandemic hit in the middle of 2020, changed the legislation very rapidly, and congratulations to them, for allowing physicians to see patients by video. However, since the pandemic has slowed down, now for me to see a patient from another state on video medicine, I need to have a license in that state, which of course is a huge problem. Medical legal concerns, HIPAA compliance, and consenting patients. And these are issues that we navigated very well, very quickly, by making sure that we have this documentation in place before doing telemedicine. So in summary, on the left, you can see the pathophysiology of ED associated with COVID-19, and it is almost certainly multifactorial. I think while there is some suggestion that endothelial cell damage occurs, etc., I think that the majority of the patients that I see who had new onset ED related to COVID-19 most probably had a psychosocial factor that was the main component. So increased sexual dysfunction in a pandemic. I hope that we'll never see a pandemic again, at least in my lifetime, but I'm not sure of that. And I think we need to learn the lessons from what went on over the last 18 months. The pathophysiology is unclear and is almost certainly going to be multifactorial. The access to care was reduced, and we need to figure out new ways of managing our patients with sexual problems through telemedicine. And we need to navigate telemedicine in an effort to optimize training of our clinicians. This is a very important factor and something that's of great interest to me over the coming years. Thank you very much for your attention.